Hello, dear students. Let's get started our lecture. The topic is chronic obstructive pulmonary disease, bronchial asthma. Definition. Chronic obstructive pulmonary disease is a common, preventable, and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases, and influenced by host factors, including abnormal lung development. Significant comorbidities may have an impact on morbidity and mortality. Patients typically have symptoms of chronic bronchitis and emphysema, but the classic triad also includes asthma or a combination of the three conditions together. Chronic bronchitis is defined clinically as the presence of a chronic productive cough for 3 months during each of 2 consecutive years. Emphysema is defined pathologically as an abnormal permanent enlargement of the air spaces distal to the terminal bronchioles. Accompanied by destruction of their walls and without adverse fibrosis. Etiology. Factors: cigarette smoking, environmental factors, airway hyperresponsiveness, alpha-1 antitrypsin deficiency, intravenous drug use, immunodeficiency syndromes, vasculitis syndrome, connective tissue disorders, celiac disease. Pathologic changes in chronic obstructive pulmonary disease occur in the large airways, the small bronchioles, and the lung parenchyma. Most cases of COPD are the result of exposure to noxious stimuli, most often cigarette smoke. The normal inflammatory response is amplified in persons prone to COPD development. The pathogenic mechanisms are not clear, but are most likely diverse. Increased numbers of activated polymorphonuclear leukocytes and macrophages release allostasis in a manner that cannot be counteracted effectively by antiproteases, resulting in lung destruction. Cigarette smoke causes neutrophil influx, which is required for the secretion of macrophage-derived matrix metalloproteinases. This suggests, therefore, that neutrophils and macrophages are required for the development of emphysema. The primary offender has been found to be human leukocyte elastase, with synergistic roles suggested for proteinase 3 and macrophage-derived matrix metalloproteinases. Cysteine proteinases and a plasminogen activator. Additionally, increased oxidative stress caused by free radicals in cigarette smoke, the oxidants released by phagocytes and polymorphonuclear leukocytes, all may lead to apoptosis or necrosis of exposed cells. Accelerated aging and autoimmune mechanisms have also been proposed as having roles in the pathogenic of COPD. In patients with stable COPD without known cardiovascular disease, there is a high prevalence of microalbuminuria, which is associated with hypoxemia independent of other risk factors. Emphysematous destruction and small airway inflammation often are found in combination in individual patients, leading to the spectrum that is known as COPD. When emphysema is moderate or severe, loss of elastic recoil rather than bronchial disease in the dominant mechanism or airflow limitation. By contrast, then when emphysema is mild, bronchial abnormalities are most responsible for the majority of the deficit in lung function. Also, airflow obstruction in emphysema is often irreversible constriction due to inflammation accounts for some reversibility. Chronic bronchitis. Mucous gland hyperplasia is a histologic hallmark of chronic bronchitis. Airway structural changes include atopy, focal squamous metaplasia, ciliary abnormalities, variable amounts of airway smooth muscle hyperplasia, inflammation, and bronchial wall thickening. Damage to the endothelium impairs the mucociliary response that clears bacteria and mucus. Inflammation and secretion provide the obstructive component of chronic bronchitis. Neutrophilia develops in the airway lumen, and neutrophilic infiltrates accumulate in the submucosa. The respiratory bronchioles display a mononuclear inflammatory process, lumen occlusion by mucus plugging, double cell metaplasia, smooth muscle hypoplasia, and distortion due to fibrosis. These changes, combined with loss of supporting alveolar attachments, cause airflow limitation by allowing airway walls to deform and narrow the airway lumen. Emphysema leads to a dramatic decline in the alveolar surface area available for gas exchange. Furthermore, loss of alveoli leads to airflow limitation by two mechanisms. First, loss of the alveolar walls result in a decrease in elastic recoil, which leads to airflow limitation. Second, loss of the alveolar supporting structure leads to airway narrowing, which further limits airflow. The gradual destruction of alveolar septum and of the pulmonary capillary bed in emphysema leads to a decreased ability to oxygenate blood. The body compensates with lowered cardiac output and hyperventilation. This VQ ratio mismatch result in relatively limited blood flow through a fairly well oxygenated lung with normal blood gases and pressure in the lung, in contrast to the situation in chronic bronchitis. Because of low cardiac output, the rest of the body also suffers from tissue hypoxia and pulmonary cachexia. Eventually, this patient develop muscle wasting and weight loss and are identified as punk puffers. Diagnosis and assessment. The clinical diagnosis of COPD should be considered in any patient who has dyspnea, chronic cough, or sputum production, and a history of exposure to risk factors to the disease. Spirometry is required to make the diagnosis in this clinical context. The presence of a post-bronchodilator, FEV1, FEV-C ratio less than 0.70 confirms the presence of persistent airflow limitation and thus of COPD. The goals of COPD assessment are to determine the severity of the disease, including the severity of airflow limitation, the impact of the patient's health status, and the risk of future events, in order to guide therapy. Comorbidities occur frequently in COPD patients, including cardiovascular disease, skeletal muscle dysfunction, metabolic syndrome, osteoporosis, depression, and lung cancer. Given that they can occur in patients with mild, moderate, and severe airflow limitation and influence mortality and hospitalization independently, comorbidities should be actively looked for and treated appropriately if present. Pulmonary function tests are essential for the diagnosis and assessment of the severity of disease, and they are helpful in following its progress. In addition to the spirometry findings that define the disease, lung volume measurements often show an increase in total lung capacity, functional residual capacity, and residual volume. The vital capacity often decreased. Dynamic hyperinflation during exercise is known to be a greater contributor to the sensation of dyspnea than airflow obstruction alone. Carbon monoxide diffusion capacity is decreased in proportion to the severity of emphysema. Spirometry is the most common of the pulmonary function tests, measuring lung functions, specifically the measurement of the amount and or speed of air that can be inhaled and exhaled. Spirometry is an important tool used for generating prima tachograph and assessing conditions such as asthma, pulmonary fibrosis, cystic fibrosis, and COPD. Staging. The formal diagnosis of COPD is made with spirometry. Then the ratio of forces expiratory volume in 1 second over forces vital capacity is less than 70% of that predicted for my chest control. It's diagnostic for a significant obstructive defect. Criteria for assessing the severity or airflow obstruction are as follows. In patients with emphysema, frontal and lateral chest radiographs reveal the following: flattering of the diaphragm, increased retosternal airspace, a long narrow heart shadow, rapidly deepening vascular shadows accompanied by hyperlucency, of the lungs. Radiographs in patients with chronic bronchitis show increased bronchoscopal markings and cardiomegaly. Patients with COPD can have sustained or intermittent hypoxia. Hypoxia can cause abnormalities in ventricular relaxation and contraction due to changes in the myocytes cell metabolism. Numerous epidemiological studies have shown that COPD patients have a risk of developing CAD with its inherent complications, and that this risk increased during exacerbation. Right ventricular function and pulmonary hypertension, usually only mild to moderate, are common in COPD. Ventricular interdependence describes a phenomenon in which both RV pressure and volume overload cause the interventricular septum to shift towards the left ventricular, modifying its geometry. Dilatation of the right ventricular also increased the constrictive effect to the pericardium, all of which can result in a reduction in the distensibility and filling of the left ventricular. Hyperinflated lungs and high intrinsic positive and expiratory pressure will decrease interthoracic blood volume and ventricular preload, resulting in hypovolemic diastole. LV hypertrophy is considered an arrhythmogenic factor and can result in the eventual onset of ventricular dysfunction and atrial fibrillation and dilatation. Electrocardiography can help establish that hypoxia is not resulting in cardiac ischemia and that the underlying cause of respiratory difficulty is not cardiac in nature. Pulse oximetry and atrial blood gases measuring. Pulse oximetry should be used to assess all stable patients with FeV1 less than 35% predicted or with clinical signs suggestive of respiratory failure or right heart failure. If peripheral saturation is less than 92%, atrial blood gases should be assessed. Exercise test. Walking test can be useful for assessing disability and are used to assess the effectiveness of pulmonary rehabilitation. Both the paced shuttle walk test and the unpaced 6-minute walk test can be used. Laboratory testing using cycle or treadmill ergometry can identify existing or alternative conditions, for example, cardiac diagnosis. Monitoring of physical activity may be more relevant regarding prognosis than evaluating exercise capacity. This can be done using accelerometers or multi-sensor instruments. Medication is used in COPD treatment. Bronchodilators, dilator medications are central to symptom management in COPD. Inhaled therapy is preferred. The choice between beta-2 agonist, anticholinergic, theophylline, or combination therapy depends on availability and individual patient response in terms of symptoms, relief, and side effects. Bronchodilators are prescribed on an as-needed or on a regular basis to prevent or reduce symptoms. Long-acting inhaled bronchodilators are convenient and more effective and producing maintained symptom relief than short-acting bronchodilators. Combining bronchodilators of different pharmacological cases may improve efficacy and decrease the risk of side effects compared to increasing the dose of a single bronchodilator. Medications used in COPD treatment. Second file. Theophylline, the most commonly used methylxanthine, is metabolized by cytochrome P450, a mixed function oxidases. Clearance of the drug declines with age. Theophylline is less effective and less well tolerated than inhaled long-acting bronchodilators and is not recommended if those drugs are available and affordable. Regular treatment with inhaled corticosteroids improves symptoms, lung function, and quality of life, and reduce the frequency of exacerbation in COPD patients with an FEV1 less than 60% predicted. An inhaled corticosteroid combined with a long-acting beta-2 agonist is more effective than the individual components in improving lung function and health status and reducing exacerbation in patients with moderate to very severe COPD. The principal action of phosphodiesterase 4 inhibitors is to reduce inflammation by inhibition of the breakdown of intracellular cyclic AMP. It's a once daily oral medication with no direct bronchodilator activity. Roflumilast reduced moderate and severe exacerbation treated with corticosteroid by 50-20% in patients with chronic bronchitis, severe to very severe COPD, and a history of exacerbation. Treatment of acute exacerbation of COPD. An exacerbation of COPD is an acute event characterized by a worsening of the patient's respiratory symptoms that is beyond normal day-to-day variation and leads to a change in medication. Currently, the diagnosis of an exacerbation relies exclusively on the clinical presentation of the patient complaining of an acute change of symptoms that is beyond normal day-to-day variation. Key points for the management of exacerbation. Short-acting inhaled beta-2 agonist with or without short-acting anticholinergics are recommended as the initial bronchodilators to treat an acute exacerbation. Systemic corticosteroids can improve lung function, oxygenation, and shorten recovery time and hospitalization duration. Duration of therapy should be more than 5-7 days. Antibiotics then indicated can shorten recovery time, reduce the risk of early relapse, treatment failure, and hospitalization duration. Duration of therapy should be 5-7 days. Methoxantins are not recommended due to increased side effects profiles. Non-invasive mechanism ventilation should be the first mode of ventilation used in COPD patients with acute respiratory failure who have no absolute contradiction because it improves gas exchange, reduced work of breathing, and the needed for intubation, decreased hospitalization duration, and improves survival. Bronchial asthma. Asthma is a common and potentially serious chronic disease that imposes a substantial burden on patients, their families, community, and their community. It causes respiratory symptoms, limitation of activity, and flare-ups that sometimes require urgent health care and may be fatal. Asthma affects 5-10% of the population, or an estimated of the population, and an estimated 23 million persons, including 7 million children. The overall prevalence rate of exercise-induced bronchospasm in 3-10% of the general population if persons who don't have asthma or allergy are excluded. But the rate increases to 12-15% of the general population if patients with underlying asthma are included. Asthma affects an estimated 300 million individuals worldwide. Annually, the World Health Organization has estimated that 15 million disability adjusted life years are lost, and 250,000 asthma deaths are reported worldwide. Factors that can contribute to asthma or airway hyperactivity may include any of the following: environmental allergens, viral respiratory tract infections, exercise hyperventilation, gastroesophageal reflux disease, chronic sinusitis and rhinitis, aspirin or non-steroidal anti-inflammatory drug, use of beta-adrenergic receptor blockers, obesity, environmental pollutants, tobacco smoke, occupation exposure, irritants, various high and low molecular weight compounds, emotional factors or stress, perinatal factors. Chronic inflammation of the airways is associated with increased bronchial hyperresponsiveness, which leads to bronchospasm and typical symptoms of wheezing, shortness of breath, and coughing after exposure to allergens, environmental irritants, viruses, cold air, or exercise. In some patients with chronic asthma, airflow limitation may be only partially reversible because of airway remodeling that occurs at chronic untreated disease. Airway inflammation in asthma may represent a loss of normal balance between two opposing populations of Th lymphocytes. Two types of T lymphocytes have been characterized, T1 and T2. T1 cells produce interleukin 2 and IVn alpha, which are critical in cellular defense mechanisms in response to infection. T2, in contrast, generates a family of cytokines that can mediate allergic inflammation. Airflow obstruction can be caused by a variety of changes, including acute bronchoconstriction, airway edema, chronic mucous plaque formation, and airway remodeling. Acute bronchoconstriction is a consequence of immunoglobulin E dependent mediator release upon exposure to air allergens and is a primary component of the early asthmatic response. Airway edema occurs 24 hours following an allergen challenge and is referred to as the late asthmatic response. Chronic mucous plaque formation consists of an exudate of serum proteins and cell debris that may take weeks to resolve. Airway modeling is associated with structural changes due to long-standing inflammation and may profoundly affect the extent of reversibility of airway obstruction. Airway obstruction causes increased resistance to airflow and decreased expiratory flow rates. These changes lead to a decreased ability to expel air and may result in hyperinflation. Many clinical phenotypes of asthma have been identified. Some of the most common include allergic asthma, non-allergic asthma, adult onset asthma, asthma with persistent airflow limitation, and asthma with obesity. Wheezing, a musical clinical signs. Wheezing, a musical high pitches whistling sound produced by airflow turbulence, and one of the most common symptoms. In the mildest form, wheezing is only expiratory. As the severity increases, the wheeze lasts through exstipation. In a more severe asthmatic episode, wheezing is also present during inspiration. During a most severe episode, wheezing may be absent because of the severe limitation or airflow associated with airway narrowing and respiratory muscle fatigue. Asthma can occur without wheezing when obstruction involves predominantly the small airways. Cough may be the only symptom of asthma, especially in causes of exercise-induced or nocturnal asthma. Usually the cough is non-productive and non-paroxysmal. Chest tightness or a history of tightness or pain in the chest may be present with or without other symptoms of asthma, especially in exercise-induced or nocturnal asthma. Typical symptoms include cough, wheezing, shortness of breath, and chest pain of tightness. Patients may note asthma symptoms and relate it to seasonal changes or the ambient temperature and humidity of the environment in which a patient exercises. Other triggers may be pollutants or upper respiratory tract infections. Cold, dry air generally provokes more obstruction than warm, humid air. This sound. Physical examination. Signs of atopy or allergic rhinitis, such as conjunctival congestion and inflammation, ocular shiners, and transverse crease on the nose due to constant rubbing associated with allergic rhinitis, and pale violations. Nasal mucosa due to allergic rhinitis may be present in the absence of an acute episode, such as during an outpatient visit between acute episodes. Turbinates may be erythematous or buggy. Polyps may be present. Laboratory and imaging of bronchial asthma. Laboratory assessments and studies are not routinely indicated for the diagnosis of asthma, but they may be used to exclude other diagnoses. Eosinophilia and elevated serum immunoglobulin E levels may help guide therapy in some causes. Arterial blood gases and pulse oximetry are valuable for assessing severity of exacerbation and following response to treatment. Total serum immunoglobulin E levels greater than 100 IU are frequently observed in patients experiencing allergic reaction, but this finding is not specific for asthma and may be observed in patients with other conditions. Blood eosinophilia greater than 4% supports the diagnosis of asthma, but an absence of these findings is not exclusionary. Eosinophil counts greater than 8% may be observed in patients with consistent atopic dermatitis. These findings should prompt an evaluation for allergic bronchopulmonary allergic and or eosinophilic pneumonia. Arterial blood gas measurement provides important information in acute asthma. This test may reveal dangerous levels of hypoxemia or hypercarbia secondary to hyperventilation and hence respiratory acidosis. However, the typical findings in the early stages of an acute episode is respiratory alkalosis. Venous levels of PCO2 have been tested as a substitute for arterial measurements, and the venous pressure O2 greater than 55 millimeter may serve as a screening test, but cannot substitute for the ABG evaluation of respiratory function. Hypercarbia is a concern in that it reflects inadequate ventilation and may indicate the need for mechanism ventilation if the pressure is elevated as a result of patient exhaustion. However, the decision to proceed with endotracheal intubation and mechanism ventilation is a clinical assessment. Sputum analysis. Microscopic sputum plaque contain walls of sheet epithelium, numerous eosinophils, and charcoal-laden crystals. A collection of crystal made of eosinophil proteins are also present. Allergy skin testing is a useful adjunct in individuals with atopy. Results help guide indoor allergen mitigation or help diagnose allergic rhinitis symptoms. The allergens that most commonly cause asthma are air allergens such as house dust, mice, animal tenders, pollens, and mold spores. Chest radiograph remains the initial imaging evaluation in most individuals with symptoms of asthma. In most patients with asthma, chest radiography findings are normal or may indicate hyperinflation. Reported features with asthma include pulmonary hyperinflation, bronchial wall thickening, peribronchial coughing, pulmonary edema due to asthma. Goals of asthma management. The long-term goals of asthma management are to achieve good symptom control and to minimize a future risk of asthma-related mortality, exacerbation, persistent airflow limitation, and side effects of treatment. The patient's own goals regarding their asthma and its treatment should also be identified. The patient health professional partnership. Effective asthma management requires a partnership between the person with asthma and their healthcare providers. Teaching communication skills to healthcare providers may lead to increased patient satisfaction, better health outcomes, and reduced use of healthcare resources. The patient's health literacy, that is the patient's ability to obtain, process, and understand basic health information to make appropriate health decisions should be taken into account. Mild asthma treatment with regular daily low-dose ICS is highly effective in reducing asthma symptoms and reducing the risk of asthma-related exacerbation, hospitalization, and death. In adults and adolescents with mild asthma, treatment with as-needed low-dose ICS formoterol reduced the risk of severe exacerbations by about 2/3 compared with SABA only treatment and is not inferior to daily low-dose ICS. Quick relief medications are used to relieve acute asthma exacerbations and to prevent exercise-induced bronchoconstriction symptoms. Controllers medication are used to control non-asthma symptoms and their severity. Prevents medication are used to prevent progression of disease and complication appearance. Signs of severe exacerbation. The presence of certain clinical findings may help to identify patients experiencing severe asthma attacks and are indicative of severe airflow obstruction. Tachypnea, tachycardia, use of accessory muscle of inspiration, diaphoresis, inability to speak in full sentences or phrases, inability to lie supine due breathlessness, and pulses paradoxes. Management of asthma exacerbation in the emergency department. Severe exacerbation of asthma and life-threatening medical emergencies, which are most safely managed in an acute care setting, emergency department. Management of asthma in the intensive care unit is beyond the scope of this report, and readers are referred to a recent comprehensive review. History. A brief history and physical examination should be conducted concurrently with a prompt initiation of therapy. Time of onset and cause of a present exacerbation, severity of asthma symptoms, any symptoms of anaphylaxis, risk factors for asthma-related deaths, all current reliever and controller medication, including those and devices prescribed. Physical examination, signs of exacerbation severity, complicating factors, signs of alternative conditions that could be explained acute breathlessness. Objective assessment, measuring of lung function, oxygen saturation. Arterial blood gas measurements are not routinely required. Chest X-ray and not routinely recommended. Is not routinely recommended. Treatment in acute care settings, such as the emergency department. Oxygen, inhaled short-acting beta-2 agonists, epinephrine for anaphylaxis. Systemic corticosteroids, inhaled corticosteroids, systemic corticosteroids speed resolution of exacerbation and prevent replace and should be utilized and in all but the mildest exacerbation in adults and children. Where possible, systemic corticosteroids should be administered to the patient within 1 hour of presentation. Use of systemic corticosteroids is particularly important in the emergency department. Route of delivery. Oral administration isn't effective as intravenosis. Dosage. Daily doses of OCS are equivalent to 50 milligram prednisolone as a single morning dose, or 200 milligram hydrocortisone in divided doses are adequate for most patients. For children, an OCS dose of 1 to milligram per kilogram up to a maximum of 50 milligram day is adequate. Duration: 5 and 7 day courses in adults have been found to be as effective as 10 and 14 day courses, respectively, and 3-5 days course in children is usually considered sufficient. Inhaled corticosteroids within the emergency department. High-dose ICS given within the first hour after presentation reduced the need for hospitalization, and patients not receiving systemic corticosteroids. When given in addition to systemic corticosteroids, evidence is conflicting. Overall, ICS are well tolerated, however, cost is a significant factor, and the agent, dose, and duration of treatment with ICS in the management of asthma in the emergency department remain unclear. On discharge home, patients should be prescribed regular ongoing ICS-containing treatment, since the occurrence of the severe exacerbation is a risk factor for future exacerbations. And ICS-containing medications significantly reduce the risk of asthma-related deaths or hospitalization. CABA-only treatment of asthma is no longer recommended. For short-term outcomes, such as relapse requiring admissions, symptoms, and quality of life, a systematic review found no significant difference when ICS were added to systemic corticosteroids after discharge. There was some evidence, however, that post-discharge ICS were as effective and systemic corticosteroids for milder exacerbation. But the confidence limits were right. Cost may be a significant factor for patients in the use of high-dose ICS, and further studies are required to establish their role. Thank you for attention.